Good afternoon, and welcome to the CIBHS Peer Leadership Institute webinar series. I'm Lisa Smooze, training consultant for the PLI and one of your trainers for the Peer Leadership Institute project. I am pleased to be joined by the rest of our team who will now introduce themselves. First, of course, we have Kimberly Mayer, who is not with us today, the Associate Director at CIBHS. As I mentioned previously, my name is Lisa Smooze, training consultant.
Hi, I'm Kristen Dempsey. I'm a Senior Associate at CIBHS, and I'll be your trainer today.
And I'm Kelly Bitts. I'm the Project Coordinator for the PLI project.
Great. And again, here's Kristen Dempsey to present today's webinar, An Introduction to SBIRT.
All right. Thank you, Lisa. Thank you for the introduction, and thank you, Kelly, for organizing today and bringing everyone together for this webinar. So SBIRT, some of you might have heard about it before. It's screening, brief intervention, referral to treatment. It's quite a mouthful, so we say SBIRT. What we're going to do today is we're just going to talk a little bit about SBIRT, kind of the philosophy or the idea behind it and why it's done. And I'm really thinking about and really want to be able to spend some time reflecting why SBIRT is actually a skill that we're focusing on in terms of the Peer Leadership Institute. Like, why might this be a useful skill for peers to have? And there's a number of great skills for peers to develop. And unfortunately, we can't teach all of them in the limited time we have, but SBIRT kind of brings together a lot of important pieces. Brings together a lot of important work that's being done right now in terms of substance use disorder treatment, brings together integrated care, kind of bridging some of the work around behavioral health with what's being done in primary care. And it's a great role for peers. So we want to be able to kind of think about this from the peer perspective. So we'll be talking about screening alcohol and drugs and the role screening plays in addressing substance use issues. And we'll be talking about, or just recognizing at this point, the role of motivational interviewing, which the peers have been trained in, and how that fits into SBIRT as well. And then we'll prepare for the next steps in practicing the skills of administering SBIRT. And we hope that you'll be able to join us next week when we actually do some SBIRT practice in person. It'll be kind of a shorter training session before our PLI graduation. So this is really kind of be thought of as part one, with next week being thought of as part two. So go ahead, have the next slide. Oh, we have a poll question. Please select your most frequent response. You may have more response. You may have more than one. And we have a poll up there. I'm afraid I can't see it from where I'm at. Okay, great. Most of the time when I want to change, and you can select one or more of the following. I just do it. I think about it for a long time. I make attempts to do it. I talk to my family and friends about it. Try to forget about it. I hate change. I'm not sure if it's up, if the poll's up yet. There we go. Sorry for the results here. Okay. Once we got zero, I don't know if we have anyone taking the full results. But the point I'm trying to put out here is that, you know, when people change, generally there's more than one way of doing it. And also, change often is a process. Many of us think about change for a long time before we actually get anywhere near change. And so what I like to think about kind of the idea of SBIRT and what it is and why we're trying to use it is that thinking about it as a way to actually help start some change, or maybe to get a spark behind change. Just knowing that people can develop some understanding about their substance use issues or the relationship to substances, and that might actually be an important piece in starting to have a conversation with themselves or with others about change. So what is SBIRT anyway? Well, I said before, it's screening, brief intervention, and referral to treatment. And we called an evidence-based practice, which means that there's research around its effectiveness. And it's used to identify, reduce, and prevent problematic use, abuse, and dependence on alcohol and illicit drugs. Okay, so yeah, go ahead and go to the next slide. So why do we do this? Well, what we did is, or what kind of the community did, and this is actually not just in the United States, but the World Health Organization really developed this broadly, internationally, and then in the United States, the Substance Abuse and Mental Health Services Administration, you'll notice down on the right-hand side, I use them as a reference in much of this, really started to address this on a national level because it does a couple of things. It really provides kind of universal screening. It allows us to see just how much substance use is out there, and really to be able to ask people, regardless of what they present for or what they're coming in for, about their substance use relationships, if you will. And then it allows us to be able to do some prevention, have conversations about substance use so people can develop some awareness. If someone has been using potentially really problematically, we can start to do some early intervention through some brief interventions, discussion, awareness, small amounts of treatment, and then we get into actually more extensive treatment because there's a number of people who come in for all kinds of concerns, whether they be for mental health issues or physical issues or what have you, and they're not expecting or necessarily even wanting or anticipating any kinds of treatment, but when they're screened, it comes up, and we're able to find out that maybe they have more of an issue than they thought, and we're able to have some kind of more deep conversations and make appropriate referrals. So this is why we use SBIRT, because all along the continuum, what we call, from just starting or thinking about using, experimenting, all the way up to potential heavier use or dependence, there's opportunities for us to have conversations and to intervene. Next slide. Okay, so this is how SBIRT works, and I want to talk a little more about screening in a minute, just kind of to get our minds wrapped around what is screening. When we screen for something, it just kind of tells us kind of yes or no if there's something occurring in the community. Now, in this case, it's around substance use. So we use different tools to determine whether someone's at low risk for a substance use issue, in which case no further intervention is needed, whether they're at moderate risk and need some kind of brief intervention, if they're at moderate to high risk and they need some more brief treatment, and brief treatment, just, there's kind of more sessions, more focused sessions, more focused interventions, to severe risk of dependency, where someone's actually getting more specifically designed and certainly evidence-based treatments to treat substance use disorders. So the idea is the screening kind of helps us determine yes or no is something an issue, and then where can we help somebody get some help, depending on what they need. Next slide. Okay, so here's kind of an important piece to think about in terms of substance use in primary care. People are coming into primary care for a whole number of things, right? They kind of, early illness. Sometimes people have more intense chronic illnesses. But what they noticed is that when they actually just started to do some universal kind of screening, they found out that maybe about 71% of the folks, about 2/3, they're at low risk use or they weren't using at all. But about a quarter of people have some harmful or risky use and could use some aspect of brief intervention. And I'll define some of these a little bit later, what's brief intervention versus treatment. And then at the very top, we have dependent folks, and that's about 4%. And here you may have some brief intervention, but you may actually need some referral to treatment. So these all seem like maybe small percentages, but you start to think about the whole population. We have over 1 in 4 people just right off the top who have potentially harmful or risky use. And we know that harmful or risky use can develop into dependency later on. So it's this idea of like working upstream. And I'm going to talk about this in a second. I have a little visual to show you. So I'll go ahead and go to the next slide. So basically, screening in general tells us yes, there might be an issue, or no, there's nothing to be concerned about. we're using a universal precaution, and we use universal precautions for a number of health and safety issues to decide like whether or not we need more assessment. So have the next slide I have that shows us universal precautions. So this happens all the time in our day-to-day life, and we don't necessarily think that much about it. And the reason I bring this up is because sometimes there's some real concerns around, well, why are we asking about substances, and should we be asking about them? And do people not want to talk about that, or is it really not much of a concern? But think about this. Like when we go to the airport, for instance, we have to go through screening. We don't know if somebody has something with them that could potentially be harmful, but we certainly, for all of our safety, kind of want to make sure that everybody's screened, right? As much as we may not like it, we kind of get it that we all have to participate. When you go to a doctor, a lot of times, whether or not you like it, you get on the scale, right? The doctor will check your weight. I have another piece down there where they often will screen for blood conditions. They check your cholesterol, other pieces. And so the idea is we're working kind of early, further upstream before something becomes a real problem, before, so if someone has an actual disease, if we're able to determine with a blood test early on that, oh, wait, this person's really at risk for, say, like cholesterol-related disorders, well, here we go. We're able to determine it earlier and do some earlier intervention. Same with weight. We can actually see if there's been changes in weight that we need to be concerned about. And my last picture there is, of course, we screen our blood supply, right? And that's a really important piece because we don't want to be passing around blood that might be make us sick. Okay, so this is all important aspects of screening. So next slide. So here, if we think about the first screening then for SBIRT, using SBIRT, it's really allowing us to get in early, to have conversations, to reduce harm before somebody already has like a full-blown issue with substance use conditions. We want to think of it as another important health screening as opposed to violating people's privacy. And it's also a real opportunity for us to engage and provide support to people that we care about in the community. So that's why SBIRT's kind of a really important piece. And next slide. So if you can certainly feel free in your comment box. We don't really have a poll on this. But these are some common images of substance use. And what I did is when I was making this PowerPoint, I was just going through and looking, at free photos to see like what might be interesting to have on our PowerPoint. And when I did a search on substance use issues or substance use disorders, these were the images that often pop up. And feel free, if you're near a text box there, to go ahead and type in what you're seeing, what kind of images that you see as you look at this slide. And so a point I'm trying to make here, as you probably have noticed, including like the scary needle and the skull and crossbones and everybody looking really miserable, is that just kind of in the public image when we think of substance use conditions, we think of death and dying and scariness and people being really in harm's way. And certainly when we work further downstream and people have had a substance use condition that's progressed, that's absolutely a real and legitimate concern. And although treating substance use conditions is never necessarily easy or never fun particularly, the further we work upstream, the less misery people have when they're actually at the point of getting help. So the point I'm trying to make is without screening, we end up seeing people way late down the road or down the stream, so to speak, and they're usually pretty sick, and it's much more complicated, much more costly. So we're really doing people a service by screening earlier. Another example I like to use is many of us are screened, like I said before, for routine problems, and I know some people who are relatively young who have been screened recently and were told they're at high risk for diabetes. And so they changed their diet, they lost weight, they did exercise, all these things they needed to do, and now they're testing really in the normal range, and they're really, really pleased, not to mention all the lifestyle issues. But thinking about what a difficult disease, diabetes is, how important it was that these folks got tested early and screened early and had opportunities to change their lifestyle. So we think of this then with substance use conditions. We have these really special opportunities to do this. So next slide. So now what I'm going to do is actually talk about it. So we really got hopefully the case has been made about why this is so important. So what is SBIRT then? Well, the first thing in SBIRT is the S, right, the screening. And what that means is that we use a screening tool. And the good news is around substance use disorders, substance use issues, there's a lot of great tools. There are a lot of tools that are in the public domain, which means that people can use them. You can copy them off online. You don't have to pay for them. And there's a lot of tools that are out there in the public domain that have been researched and tested and have been shown to be reliable. That is, when people complete them, the results usually correspond to kind of a certain amount of measurement or indicate a certain level of relationship to the substance. That is, they're reliable over time. They're valid, they're testing what they're supposed to test, and they're reliable in that they're consistent in being able to actually screen for those particular issues. So we're going to talk more about these different tools and practice with them, but there's a number of them, and some of them are more or less detailed. And what we often find is that we can have certain tools, usually with a few more questions that might have a little more sensitivity. We call it sensitivity, which is they're able to find, kind of more subtle nuances of someone's relationship to substances. But you don't have to have like a huge, kind of overwhelming tool that takes a long time to really get some written information. For example, we have the cage here. And you'll notice in blue, I have the words that make up cage. So this is actually from Johns Hopkins, and it's used pretty much all over, and there's, I believe, adolescent version as well. And the cage questions are, have you ever felt you should cut down on your drinking? Because one of the things that we tend to notice is that people who have a substance use concern drink more, and that often they or people they love are concerned about the amount they're using. And again, this one here is for alcohol, but there's also that are also around drugs as well. Have people annoyed you by criticizing your drinking? So again, if somebody has been using to a point where there's problematic drinking, then often other people are getting involved and making comments that can be annoying to the person drinking. Have you ever felt bad or guilty about your drinking? Okay, so this idea of people having some shame around the amount that they're using. Either, they know internally or other people have said things. And then the E in cage is a little bit more subtle in some ways. Have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover? We call that the eye opener. So what we find with the cage is that if people have a certain number of responses, it can show a certain level of relationship to substances. And that then helps inform, well, do they need a brief intervention? Do they need some brief treatment? Or do they need to actually have a referral to treatment? And next slide. So we have another poll questions. Just put some poll questions in here to kind of make sure people are able to engage here. The cage questionnaire has been found to be accurate in identifying 60 to 70% of alcohol abusers. What do you think, true or false? Okay. Oh, I'm not sure. I don't actually see the. Did you see the results there?
Yes. So 100% said true.
Okay, great. I'm glad I got that cleared up because all I see are zeros in my head. So that's good to know. And that they would be right. 100% are right. It is true. I realized that since the last slide I got zeros too. I thought no one was responding, but people are responding. So thank you. And that's very helpful to be able to have that level of ability to actually see, to figure out if people are actually using, and then you can start to really engage them in a conversation. So again, the idea around this is not to be punishing anybody. The idea is to be able to open up a conversation. And there's an idea, like if we don't ask, people won't necessarily tell. And it's not because people are trying to hide out, it's just, may not occur to them, or they may not feel like it's appropriate, or may not think anybody even cares. So I have another little slide here that just shows some different types of screening tools. Right now I won't spend a whole lot of time going through them, but what I wanted you to see is, depending on where you work, your location, there's a number of different you can use, and they're validated in different environments. So there's some for adults, and as I said, the cage is just second from the bottom for adults and youth greater than 16, actually. So we have the craft for adolescents, so maybe a little bit younger. We have we have the DAS 10 there for adults, and then the audit. We have the assist and the audit being for adults and adolescents and validated in many cultures and languages. The tweak for pregnant women down at the bottom. So you're able to really be able to go through and look and decide, which screening tool might be useful. Now, for many of us, we're not necessarily in a position where we as individuals can decide this. Often we need to decide in collaboration with our teams and the management of whatever program we're working in. But the point I'm trying to make is that screening doesn't have to be one size fits all. In fact, it shouldn't be. And that we have a lot of screening tools that are really identifying a number of different conditions. And there's screening tools for many more things besides substance use. But even just in the substance use world, we can look at things that are more culturally appropriate. We can have some flexibility in how we respond. We can think about ages, and many of these are in different languages as well. Self-administered, and it was self-administration, which means people take it themselves. They don't talk to somebody who takes their answers. There's some good things about that, but sometimes if somebody can't read very well, or or if they have questions and they're not really sure, they might just kind of fudge an answer just because they don't really know exactly what to say. So sometimes the interview can be more useful, but some people are very uncomfortable being asked about their substance use. So the point is it's nice to have different options, and that it isn't just about one size fits all. All right, next slide. Okay. So here's what we know then is, after the screening, depending on the tool. So I don't get into in the webinar here. I don't break it down for each tool, which tool might indicate what level of intervention people would need after the screening. We're going to talk more specifically about that next week, just because for a webinar it might be a little tedious to kind of go through each of those pieces, whereas when we're actually practicing, it'll make more sense, and I'm assuming it's going to be more interactive, and we can actually see videos and practice and really experiment with what this feels like. But basically, you take a screen like an audit or a cage or what have you, and then depending on the number of questions people answer, you have a sense of, well, this person just needed a brief intervention, which is just kind of a discussion, thinking again about prevention, helping people make sure they're making choices that are useful for them around substance use, just increasing awareness. Brief treatment, and brief treatment is where people may have more of a relationship with the substance that could potentially be an issue that we have some concern about. So with brief treatment, we're able to just be curious with people, help them explore, maybe do a couple of sessions. Or we might say, okay, this person actually, based on their score, really probably would benefit from some very specific specialty treatment around substance use disorders. And again, if someone isn't getting that, someone has that kind of relationship with a substance and they're not getting that kind of help yet, I mean, this is a great, in all cases, but especially if somebody's really in great need, this is a really important intervention. that we're providing that people might not have any access to. Next slide, please. We have a full question. Okay. All right. How many people in primary care are estimated to be positive for some level of substance misuse or dependency? So you select one. Oh, so this one I'm actually able to see the results.
Oh, okay.
So that's great. So we have 5 to 20%, and 15 to 30% receiving 2/3 and 1/3 alternately. And you can see there's definitely some overlap between even those. And we do have about, usually it looks like 15 to 30% often will sometimes screen for some level of substance misuse or dependency. So the point is that this is actually a really helpful piece to actually go through and be able to identify, who's at risk, and knowing that again, some people have this ability to know and kind of understand that, and others don't. So when we're in a primary care physician, especially, people come in for all kinds of reasons, and yet this is actually just as important in a lot of ways as any of their other screening. So I'm going to just talk a little bit about, as promised, the definitions between brief intervention, brief treatment, and referral treatment. So with brief intervention, what we're doing is we're educating about substance use disorder, and here I have on the slide, we call it SUD. You ever see the abbreviation SUD? It sounds kind of funny, but it's a substance use disorder, and that's actually a new term we use instead of saying substance abuse or even addiction. I mean, it's more broad, and it's able to recognize that people use along a continuum. Some people have a mild, moderate to more severe use. And so with brief intervention, we're doing a lot of education. So this is really where we're doing certainly harm reduction on some level, but we're really aware of the importance of prevention and some of the real earliest intervention, just increasing motivation to change use, to be aware, and to just give people an opportunity to acknowledge and to be able to look at their use and any potential impacts. So again, if you're thinking about some of the work that we've done in motivational interviewing, or maybe you haven't worked in the PLI, but you've had other experiences with motivational approaches, you're trying to develop some kind of discrepancy between what people are doing and what they care about, maybe even what they're doing in terms of using and any potential consequences, just to increase some awareness. So it's 1 to 5 sessions lasting 5 minutes to 1 hour. So what's nice about this is that with brief intervention is we're not just saying, oh, well, they don't really have a problem at all, so we're just going to not say anything, because there's a lot of people out there that, yeah, they don't have a problem now, but they will have one. And so we're trying to get in early just so they can be informed and make better choices. And we find that people, especially in a medical environment, when people are able to be provided education that's non-judgmental, that's thoughtful, that's conversational, educational, that it tends to be really appreciated, and that can in fact change behavior. So brief treatment, now we're looking at more structured interventions, because we give brief treatment to people who are not, or maybe more to mild, kind of early moderate in terms of the substance use disorder problems, people who aren't necessarily at the point of needing real specific more intensive outpatient or residential treatment, but people who definitely are kind of further along the continuum and maybe using more habitually, maybe having more consequences as a result of use. Maybe I'm thinking, again, it's related to the habitual aspect, but substance use is more kind of woven into the fabric of their life. And so they're more at risk. if anything, just because of the amount and maybe because of the increased consequences. So now we're talking about 5 to 12 sessions. So we're looking at maybe a month to 3 months of meetings. And the sessions can vary in length. Sometimes people are seen in groups. It can be more educational. But, clearly individual work is often very helpful as well if, there's actually a structure for that. And just to let you know in terms of how this might work in a primary care setting, some of this brief intervention and brief treatment can be kind of delivered by a number of staff members. It could be, and sometimes you'll see a doctor even doing some brief intervention, like in the emergency room or in the consulting room, like it's just one, just a couple of sessions over time, because doctors might have enough time to do that. But often this is done by nursing staff or counseling staff. And increasingly, there's ways that people are thinking about how peer providers might be able to provide some of this intervention or education, even if it's within the realm of being kind of rehabilitation oriented. Okay, next slide. Referral to treatment. So this category is reserved for those who score high enough on the screening tool, and with further assessment, it's been determined that they'll likely benefit from specialized substance use disorder treatment. So here's the thing, is that if I'm coming in because I'm having a stomach ache, and then I do the screening, and it seems like, based on my audit or whatever tool is used, that I should really probably have a referral to treatment, am I going to want you to go to treatment? Am I going to be like, great, thank you for screening me, I'm really excited about going to treatment? That's possible. That's really possible, but I think most of us know that not everybody who needs treatment is really eager to necessarily go. And it's just because change is challenging. It's because people's relationship to substances, substances have a purpose in their lives. There's a reason people started to use, and it's hard to shift behaviors. And it's hard to figure out, like, what else can I do instead? And in some cases, of course, maybe a lot of cases, it's physically uncomfortable to actually stop using. So there's a lot that's done, I think, in the referring agency in terms of helping people to motivate and engage in some conversation, and to actually then make that referral to treatment. So we're doing things differently than we used to. And it used to be, we were at an agency that wasn't a specialized substance use agency, didn't provide any treatment, that would be like ticket agents, like, okay, well, here's your ticket to travel down the road to the substance use treatment. See you later. Here's the phone number. Go get them. And of course, how many people actually would then show up? Some might, clearly, if they could see that they were in need. But a lot of times people don't do that, and that's not because they're being resistant or difficult. It's just it's not really synced up right. The linkage needs to be made. So we talk a lot in our work, in rehabilitation work, and in certainly in substance use treatment as well, about the idea of linking people to care, because people with substance use disorders and a lot of other needs, they don't show up necessarily where they should be in terms of treatment all the time. They show up where they can, and that might be at the primary care office or in a mental health clinic or what have you. And so we need to make that link between where they show up and where they need to be, so to speak, or where they're going to get the best treatment for that particular issue. And so part of that's learning like how to motivate people, and again, it's like having conversations and being able to educate, and part of that is helping people understand their behaviors and how that's helping them or not helping them function in the world, and the consequences of that, and really helping to generate some of what we call motivational interviewing change talk. Because it's a change talk that's going to get people to be willing to start to make considerations to go to where they need to go for treatment. Also, when we're referring, we want to be really thinking about what are people's practical needs. We have people who may not want to go to treatment just because, what am I going to do with my kids while I'm in treatment? or I work during the day. I can't go to this treatment program. So we might have to be really thoughtful and creative and have conversations about different supports, different types of programming. There's programs that are like working people programs where you go at night and maybe you go a few nights a week. And for some people that might work. And some people really need residential, but some people they might be able to do something like a working person's program. And this idea of a warm handoff, and that's what we call the linkage. But the idea where we're more of a travel companion as opposed to a ticketing agent. So instead of giving somebody a ticket to go down the street to the treatment center, we might find a way of connecting them. If it means we go down there with them, or we at least make a phone call and have names, and we maybe follow up when somebody's there. It takes a little more effort, and sometimes people will say, well, I don't really have the time for that. And, you know, because I have so many people I see. And the thing I say around that, I mean, there's certainly the piece of we want to be there for people in whatever way we can, and how do we find ways to work more efficiently so we can make time for those extra pieces that are so important. But my answer to that is, too, it's like, well, listen, if we don't do the warm handoff, I mean, warm handoff is not just nice, but it's also strategic. It's like without a warm handoff to really connect people well, people may drop out, or they may be back, you know, even more in need and really struggling. And ultimately, we would have saved more time, more of our time, more of our agency time, if we just put that effort in a little earlier upstream and got somebody better connected the first time around. Because people keep kind of coming back, and each time they come back, they're more in distress. I mean, it's hard on a lot of levels. It's certainly hard for the system, but ultimately, it's really obviously very painful for the person to have to be bouncing back and forth between treatment providers, or just kind of in limbo. We get a lot of folks sometimes who get in limbo. And the idea of the warm handoff is to really help prevent that. And of course, ultimately, you know, we're really helping to prevent people from being lost to the system entirely. So we have people sometimes who, if it gets really frustrating, it's just like, I'm not going back to anything, you know, and they end up really sick, or in hospitals, or on the street, or in jail, you know, in other institutions where nobody really needs to be, if we can prevent it. Okay, so we'll move on to the next one. And I'd just like to say about that referral to treatment piece, one very cool piece about that is next week is we're going to practice all of those skills around how to engage a conversation with somebody who needs more treatment, and how to make that a warm handoff. Learning the skills of warm handoff is like very, very useful no matter where you work. So we'll be talking about that. Okay, so what are we learning about screening brief intervention? So there are literature reviews that are kind of magnificent. I mean, they are really enormous, where they're looking at research, lots and lots of research around SBIRT. So it has been researched, and sometimes there's things about, oh, well, there's mixed results. And I think when you hear of mixed results, from what I can tell from the literature review, there's some challenges that some organizations have in setting up SBIRT. Like people aren't always sure about who should be doing it, and how does it fit into the overall workflow. So there's ways that sometimes screening and brief intervention gets stymied or stuck, not because the people doing it aren't doing it well, it's because the system doesn't quite know how to integrate it in. So that's one issue. That's kind of a management issue, a systems issue that has to be dealt with. But what we're learning about when people actually do screening and brief intervention is that screening and brief intervention can reduce alcohol use for at least 12 months in non-dependent heavy drinkers. So that's a big deal. Like if we're reducing for a good significant amount of time like that, yes, these are people who are non-dependent, but they had been heavy drinkers. I mean, they were on their way probably, given what we know about the progression of substance use disorders. They were probably well on their way. And to actually reduce and to do some harm reduction really upstream is really important. They also found, at least in terms of gender and age, that SBIRT interventions are acceptable kind of cross-gender and amongst people of different ages, so that's good. That means in different places we might start to think about SBIRT, like college clinics, where we see a lot of college students coming in, and of the binge alcohol users in our culture, most of them tend to be concentrated in colleges. So to be able to have conversations with college students about substance use is time really well spent, because these are the bigger health issues that college students have, for instance. And again, if somebody's going to have a substance use condition as an adult, it starts when they're younger, starts when they're adolescents and college students. So this is a great time to have the conversation. And they find that screening and brief intervention, they're using it for smoking. Now they're asking about smoking. And they're also starting to do some research, and I've seen some newer studies about cannabis, about marijuana. So they're starting to ask, and there's certainly enough people in our culture now who are using marijuana regularly to where it's a good thing to be checking into. Again, just to be seen, like, what's the relationship to it. So there's a lot of folks using cannabis, for instance, for medical issues, and then being able to just at least to have conversations. So there can be some awareness around, yes, I'm using this for a medical issue, and is it actually helpful with the medical issue, and am I having other consequences because of the use? Just to be able to have some discussions actually really critical. All right, well, the next slide, please. Okay, I do have a little space here that I left for any questions that people might be having about any of this. I don't know if we have any questions that are lining up in the queue.
We don't have any questions at this time. So let's give people a few minutes to type in your questions in the question box.
Great.
Kristen, do you want to talk about next week's training a little bit here?
I will. If any questions come in between now and then, I will gladly entertain them. So for next in-person training, May 12th in Sonoma, May 13th in Solano. And if you haven't registered, please contact Kelly ASAP so we can get you signed up. It's a big day for us because it's the end of our Pure Leadership Institute, which has been just a really wonderful experience for all of us involved. So in a way, I know it might sound kind of funny, but this SBIRT kind of training, it's not going to take the whole, it's going to be a couple hours, it's just some practice. So we'll be practicing with screening tools and role plays, various situations. I think you'll find entertaining. But what I think is kind of funny about this, I'm kind of thinking of it as kind of like a capstone kind of experience, like culminating a lot of different skills that the peers have been learning over the year. So this idea of thinking about working in integrated environments and practicing motivational interviewing and continuing to be in a relationship with people and more handoff. It's all kind of these skills that we've been building over the last 12 months. So really encourage people to come and check it out. It's going to be a little more juicy than, a webinar describing what SBIRT is, but we wanted to get some of this kind of taken care of so people could just understand some of this conceptually. And I'm encouraging people to bring a smartphone if you have one. If you don't have one, it's no big deal. But the reason is there's actually probably a number of them, but I have the free SAMHSA SBIRT application that you can actually put on your phone. And it's really cool because you have like a little mini SBIRT format. So no matter where you are or how you're doing it, I can show you how to use it, and we can actually practice with that. It makes the SBIRT process really contained and kind of fun and easy to access. But if you don't have a phone, it's okay. We're going to have lots of handouts, and they'll just be resources. We won't necessarily go through each and every one, but you'll get a chance to actually see different screening tools, and then I will have you practice, and I'll demonstrate putting this all together. So we'll see what it might look like to do a brief intervention, and what it might look like to do brief treatment, what it might look like to do a warm handoff. And even if you don't think that you're ever going to be interested in doing any work in this area, like, oh, I don't know if that's something I want to do, I don't know if I want to work in primary care, just being able to ask people screening questions and being able to do the warm handoff are skills that you'll be able to use in almost every behavioral health environment that you could possibly work in. So for that reason, I encourage you to come. So you'll also be able to see SBIRT in action. So I'm going to have some videos, which are kind of fun, because you get to see, like, the bad, non-SBIRT judgmental doctor who's really not doing anything right. And then you get to see, someone using an SBIRT kind of process. And it gives you a real feel for what we're trying to do in terms of building a non-judgmental, open screening environment. And then also it just gives you a chance to, like I said before, really practice your motivational interviewing. And then the real fun will come afterwards, because we are going to have a Peer Leadership Institute graduation in both days. And we're going to have opportunities for, I think, for some fun participation, certainly optional, but fun opportunities to participate. We'll have, certificates and such, and guest speakers and such. So I think you'll find it really entertaining and a nice way to finish and honor all the hard work that everybody has done who's been part of the PLI. And I think that is what I have. I don't know if any other questions have rolled in. That the slide.
Kristen, we don't have any questions at this time. I think everyone's keeping them for the actual in-person training.
Okay, nice.
You made it sound
that's great.
exciting, which it will be.
It will be. It'll be fun. I guarantee you, it'll be fun. Be funnier money back. I think. Do I have another slide? I don't know. That might be it.
You do. You have a couple more slides here.
Oh, I do. Okay. How about that?
If I can get my computer to work again, I think it went to sleep.
Uh-oh.
There we go.
Aha, here we go, yes. A couple more slides I wasn't going to necessarily explain, but I do want to show them to you. Selected references, and when I put this together, I did do a fair amount of research for each of the pieces that I talked about. So I said before, SAMHSA is a really important resource for anything SBIRT. And if you just put into a search engine, SBIRT and SAMHSA, you will find more stuff than you can possibly imagine. But there's also, I have like hyperlinks on here where you can actually see more PowerPoint and more just discussions. And I've tried to find things, because as you can imagine, there's like tons of research on this and just all kinds of information. And I tried to select the things that were a little more readable and I think easier to kind of access and get to and think about. So, so we have some basic research, but we also have some tools. And I think we have some on the next slide too. You see how everything in the cage. You're going to get a lot of screening tools though on next week. Yeah, and then I have on this last page, this is like TAP 33. So we have on SAMHSA, and I do say we because SAMHSA is part of our Health and Human Services and of the United States, and I guess our tax money pays for all the great stuff that SAMHSA produces, and it's all free. You can go on and click on links, and you can find all kinds of things. I actually have students of mine go in and get, entire books that we use in class, and they're great books, and they're free. So instead of paying $150 for a textbook, they have the SAMHSA resources, and everything that SAMHSA puts out is really researched by the people who are the top researchers in the field, and the top clinicians. So you're getting really high quality material. So what I would recommend you do is, like, if you want to check out Series 33 there that you saw on this hyperlink, and again, if I see you next week, I can show you directly how to find this stuff. You can just download a whole book on SBIRT, and it has all kinds of tools and explains it. So you may not be studying it every night right now. You may not have that level of interest, but it's nice to know that there's this resource and that they're out there and that you can have access to them. And so I just want to make sure that you had knowledge of those particular resources. And I think that's all I had for that slide.
Sorry, Kristen, I made it all the way through the webinar, and now I'm getting challenged.
Uh-oh.
There we go.
Oh, there we go. Yay, thank you. Okay, great, thank you. Okay, so this is my information. If you have any questions, I am more than happy to field any questions or to help you think through or find resources. And I certainly thank you for being here today and dialing in. And I know a number of you are dialing in after the immediate live webinar. So in everyone's case, thank you again, and I look forward to seeing many of you next week on May 12th or May 13th.